Go ahead and get started. There's probably going to be a couple people that actually log in a couple minutes, but we have a lot going on, so I think it's a good idea to get started. Good afternoon. Good afternoon for everyone, I would think. Everyone, my name is Adnan Al-Saidi. I have the privilege of being the chair of Education and Training Committee this year for the AHPBA, and we welcome you all. Many people here are new to the AHPBA, and this is the whole point of this, is to kind of gather, get to know each other, learn something, but also network.
Okay, we'll start again. So thanks again, good afternoon. As planning for this fellows course, it really seemed necessary to include a segment on how to improve efforts around diversity, equity, and inclusion, as well as understand where you all can take a stand. And I realize that many of you have already received some cultural competency training probably in your career so far, but these are themes that need to be continuously encouraged and enforced. I think this is a really nice framework for remembering on how to enforce this process. This is REAL, or R-E-A-L, which stands for Revealing Opportunities, Elevating Equity, Activating Diversity, and Leading Inclusively. We will go through each of these steps, but it's a nice way of remembering things. The first step is about discovery. So not really just setting an agenda or trying to duplicate diversity initiatives that seemed effective in other places. It really involves gaining awareness of the types of diversity that already exist in your setting and the context for which DEI can improve across individuals or teams or whole organizations as a whole. So opportunities and strategic actions will be different across a society level, for example, or an institution or a department, just depending on different needs. For example, at Stanford, our surgery DEI cabinet has 4 subgroups. These are faculty, residents, researchers, and staff, and we do this to identify action plans at each level. However, it's really important to recognize that as HPB fellows, you are in a position of leadership. You may be starting on committees or form research collaborations or be involved in clinical trials. And certainly a huge part of your leadership is in the training of residents and medical students that you interact with daily, that you round with, that you assign conferences to, that you may joke with or interview or mentor. And it's important to remember that residents are at high risk for discrimination because of power differentials between residents and faculty, and also because surgery hasn't really diversified as quickly as many other fields. So please don't underestimate this role to intervene. These trainees look up to you and you can make a real difference. In terms of revealing opportunities at this level, this is data that shows there is a real need for this at the trainee level. This comes from my friend and colleague, Dr. Yu Young Hu, who is a pediatric surgeon at Northwestern and involved in surgical outcomes and quality improvement there. She has been involved in the first and second trials, which are supported by the ABS, the American College of Surgeons, and the ACGME. And these look at how to intervene along the lines of duty hours, discrimination, and wellness issues among general surgery residents. I'm sure many of you remember the surveys that are given at the end of ABSITE, which is the annual American Board of Surgery in Training exam. The surveys are optional and de-identified. The 2019 survey included specific behaviors based on race, ethnicity, or religion, as well as the frequency and source of these occurrences. And they also looked at some of the wellness measures associated with this. So 86% of residents responded with race and ethnicity breakdown, and this can be shown here. So the majority being white, the smallest identified group being Black or African American, and smaller groups of Asian and Hispanic. And over 5,000 responded to the relevant questions. Among all residents, 24% reported some racial discrimination. And of the non-white residents, this number is up to 41% of the total. And the range of frequency was a pretty common experience for those that are not white. If you think a few times a month is not so often, honestly, that's almost every other week to have to deal with this in addition to working super hard. For specific behaviors, the source came from across all groups. If it was for standards of evaluations or being denied opportunity, 2/3 came from attendings. If it was to be mistaken as a non-physician, or slurs or hurtful comments, these mostly came from patients or families. And sadly enough, if it were comments regarding feeling more socially isolated, these came from just their individual peers or colleagues. Being mistaken for another person of the same race oftentimes came from nurses or staff. The residents that reported discrimination also reported higher rates of burnout, attrition, and suicidal thoughts. So again, this emphasizes a true opportunity of intervention for you as a fellow. Remember that 41% of non-white general surgery residents reported discrimination, and although strategies have to be employed in a very context-specific area, you're going to have a lot of residents cross your service, even in 1 year, who are looking up to you as their leader. And you can address this by listening and being aware and providing opportunities. It honestly starts with the small things. Don't underestimate that assigning an underrepresented junior resident to present a case and then helping them prepare for it to shine in front of a faculty conference can really motivate them and even give them opportunities to consider our field. The next part in our framework is elevating equity. To make progress on expanding diversity and inclusions, we have to acknowledge that there are social inequities and recognize that unintentionally, their group or organization is not a level playing field. So people advance through their careers with different opportunities, privileges, or powers, so that what is fair is not always the same for everyone. And commitment comes from setting a criteria, clarity, and consistency. You need to clarify what the position entails before actually starting your evaluation, because it's really easy to drift decision-making in what you see in a resume as opposed to what you are really looking for. So it's important to apply the same criteria for everyone and make sure the benefit of the doubt is given to all. I mention this because soon in 1 year, you may be in a position to be interviewing people that work for you, staff, nurse coordinators, research residents. And it's important to set these goals and remind yourself of these things. Here's what I mean about uneven playing fields. This is from 2018, but in a survey of academic surgeons with greater than 15,000 responses, clearly you can see that there are significant disparities that exist between males and females, and whites and non-whites. And although hiring diverse staff may help to start eliminate these disparities, that's really not enough. They may not have all the same resources and support that they need to continue to get promoted or cultivate their careers. So there's a need to also have the courage to deliberately ask or provide them with extra opportunities. Thank you to Ms. Jill Wilhite, who was able to capture this data for me. If we look at our own organization, the AHPBA, we actually have not been collecting ethnicity or racial data, but we do have gender data. And we can see clearly there's a predominance towards men overall, but in the trainee age group, there are more females. So there may be more students and residents that attend our meetings or present at the conference, but how do we work to retain them in our society or promote them in areas of leadership? These are interactions that can make a difference at these meetings. Certainly if I look at the group that I fall into now, this 41 to 50 age group, the percentage of my female colleagues drops down to 16%. Even in your own group, this is the data for the current HPB fellows of 2020, which supports the continued racial and gender disparities still exist. But now that we have started collecting data like this as a society, the AHPBA can start to create mentorship models to help underrepresented junior faculty to succeed in their careers. So to remember, please, to remember to elevate equity, be transparent in your policies regarding recruitment. You have to publicize and encourage opportunities, publish stats on gender, ethnicity, ranks, and demographics. This is a good way to start, but it helps us to keep track of how we were doing. And we have to intentionally promote those that are not well represented. Finally, we get to diversity. I purposely put it a little bit later on because I think it's important to set the stage for diversity and not just start out with it. Clearly, it's important because it leads to innovative solutions and creative ideas. It is important in healthcare as we are more likely to address differences in different areas or demographic groups if we are diverse care providers. We must keep up with changing demographics and work to recruit and retain the most talented and we have to improve research and clinical trials, because if we do not incorporate diversity in these areas as well, we may not achieve outcomes that are generalizable to everyone, and therefore we facilitate persistent disparities in healthcare. Diversity is more than just race or gender. We have to recognize that it includes all aspects of human differences, such as socioeconomic status, language, gender, disability, religion, sexual orientation, or age. These are all important factors. The demographics of our world are also changing, and so the minority is becoming the majority. This is from the NIH, where they showed that in so many different avenues, whether it be scientific or non-scientific, having a diverse group of random people oftentimes came up with more creative and more innovative solutions than just having experts in the same field. And this was even applied to something as silly as guess the weight of a cow, where they took experts that were, in cow herding and cow raising and everything cow, versus just a random group. But still, the more accurate group was that was more random. So if we look at the demographics, we want to meet the goal of taking care of our population in the best manner, and we have to realize that actually the minority is becoming the majority. We would have said that would have happened down the line, but certainly it's coming around more sooner than we think. And if we want to meet the goal of taking care of our population in the best manner, we have to incorporate strategies to recruit from all diverse populations to represent this change. Just this week, the AHPBA put on a webinar on the importance of DEI in clinical trials to support this idea of providing better care towards poorly represented groups, such as women, elderly, and underrepresented minorities. Often the barriers to trial participation are multifactorial, and we can do a better job of linking patients with community providers or navigators to bring them into study populations. Patients are more likely to come join trials when people who run them look like them. So providers and staff need to represent catchment areas of populations who they are serving and look at ways to overcome system barriers. And finally, everyone always wants to know where to start, how to lead inclusively. Inclusion requires active, intentional, and ongoing efforts to promote the full participation and sense of belonging for everyone. It may involve changing policies, but also involves new ways of leading and thinking. It involves incorporating an inclusive leadership to bring in more diversity, to identify and mitigate bias, and to learn to take a stand and be an upstander for those that are targeted. Bias clearly influences the way we view our lives, but can also often be thought of as a cognitive shortcut to categorize things. This comes from the Facility of Diversity and Development at Stanford, but it's a good way of looking at how biases come into our life during stressful situations. They are often activated when we are under conditions to try and save time or stress, or when we're multitasking or need to gain closure quickly. They can manifest in many ways, but often as small microaggressions that can add up over time. An individual may have a certain intent, just trying to tell a joke or find common ground with someone, and then they enact a behavior which has a certain impact. The impact can have an intended consequence or an unintended consequence on an individual. But maybe a simple question such as, where were you born, just out of curiosity, can be interpreted as you look different or you're not American. Something we can try to do is to work to address bias is be an upstander or an active bystander, one who speaks up and gets involved. There are two ways to do this. You can intervene directly, especially if you are the leader in the room or in a leadership role. For times that maybe you are in a room or you correct a situation where a resident is mistaken as a housekeeping staff or not a physician. Or you can follow up with the target and the team saying this is not a behavior we allow, and follow up with the offender to understand the impact of the actions made. Often due to unconscious bias, people who are not like their manager or their boss or their dominant leader don't always have equal access to the leader who can steer them towards valuable experiences and support them through inevitable challenges or complications. So effective mentoring is really a key part to supporting diversity. If you're a mentor, I encourage you to listen and be reflective with your mentees and reconfigure what it means to be an expert. I think we traditionally think of experts as people with a lot of professional experience or numbers of years in the workplace. And that's the traditional way of thinking things. But there's a lot of different expanded things that other people can offer, like technological fluency or experience in conflict mediation or emotional intelligence. And this can sometimes be considered as reverse mentoring, where we're learning from the person that we're actually trying to mentor. So it's when younger professionals also have something to offer us so that the relationship is positively mutual and reciprocal. Oh, I'm frozen. This NIH toolkit on diversity best describes this mentoring as relational rather than hierarchical. I like this thought because advisors usually convey disciplinary or academic knowledge, and certainly role models inspire through example. But the end goal of effective mentoring, as it says here, is a strong working alliance built from trust and communication. And this is an area I really think that you as fellows can contribute to your trainees. So I will leave you with our society's commitment to improving efforts around diversity and inclusion and acting purposely against racism. This is a message from Dr. Pollack, the president of the AHPBA, that lists the new initiatives that we aim to accomplish in the coming years. Establishing a new DEI committee, avoiding manels, which are meeting panels consisting of only men in the field, establishing travel grants and mentorship opportunities, and increasing leadership opportunities for URMs. Essentially also opening it up to town hall webinars to really listen from our members how we can continue to increase efforts on diversity. If you are interested in joining the new DEI committee, an email was sent, and Jill Wilhite can also send a link so that you can apply for this new committee and contribute towards facilitating DEI in our society. Thank you for your attention for this important segment. I really want to thank some of the faculty listed here that have helped to educate me on DEI and help me move forward in trying to, include this into our society as well as I would like to thank those faculty that have mentored me. So Dr. Wren, Dr. Facioto, they are parts of diversity and development at Stanford. Dr. Hu, again, I mentioned she's involved in a lot of the general surgery resident wellness. Dr. Clark is the chair of the AAS DEI task force and will be helping out with the AHPBA DEI committee as well. Ms. Jill Wilhite, who is involved in everything and really helped prepare some of the data for the slides. And thanks to both my mentors, Dr. Visser and Dr. Pollack, who have certainly opened up many doors and opportunities for me to succeed in my career.
Thank you, Dr. Duda. That was really wonderful and timely. And I actually just want to make a comment. We have maybe 2 minutes, but I just want to make a comment that Dr. Duda actually brought this topic to our committee and was very passionate about it. Thank you for putting together that really wonderful presentation. Any comments from or questions?
And thank you to Ms. Wilhite, and I think that she put the link into the chat box. And I know it was a lot to cover, but I really wanted to be able to touch on certain themes. And I think the hardest part is a lot of people want to get involved and just don't know where to start. And it doesn't mean that you have to actually be a leader somewhere or, a leader in an organization. You are all your own leaders in your own teams and groups. And so just thinking of the small things can make a really big difference. Thanks again.
I think that Dr. Jeyarajah has a question.
Just a question for you, Monica. You know, I'm as passionate about this as you, and I'm so thrilled that you took this on because it's a tough topic. Do you know, could you mention your thoughts on how we start to move the needle on unvisual bias? Because so much of what we're focusing on is gender and ethnic bias, but we so ignore things like you know, LGBTQ issues, trans issues, etc., that we really need to pay more attention to. Do you have any thoughts on that? Because I think this is just such a hole in how we approach this.
Yes, and I think that you're exactly right. When you look at the, you know, the diversity slide that I put up there, it has to move from just 4 hexagon boxes that used to be just females or, you know, race or male, female, or ethnicity, but now there's just so many. Even, you know, we recently had a lecture on ability or disability. But I think a lot of that is just first producing awareness. I have to say that the AAS has done a really good job about that, and they actually did a webinar on LGBTQ in academic medicine, and a great panel actually on, you know, promoting that not just in their academic societies, but in research and in trials. And I think just having a panel that spoke on it very openly and freely already opened up a lot of doors, you know, on people to contact and how to include that into their own societies. I mean, I myself involved, that was like the first webinar that I had really watched that involved, you know, that type of diversity. And I think that's just a starting point there, is just identifying some of those other groups that we don't always talk about and finding people that are willing to share their experiences and open up to talk about them so that you feel more comfortable addressing those kind of disparities just with people or your trainees or within your organization. Okay, Dr. Hagopian, you want to go and follow me next?
Yeah, so thank you, Dr. Duda. I am Ellen Hagopian. I'm a hepatobiliary surgeon at Hackensack Meridian, and I'm the co-chair of Education and Training Committee with Dr. Al-Saidi. Today, I'm going to talk to you very briefly about operative ultrasound. As I hope most of you know, next week we will have a shortened virtual ultrasound course, and I'm just going to talk to you about a couple of brief issues in operative ultrasound, just to kind of set the stage for next week. I have no disclosure. So why use ultrasound, right? Like, isn't ultrasound used by radiologists? Like, why do we use ultrasound in the OR? Well, because it helps us, right? Helps us find answers. Helps us find answers to questions that we don't know, or answers to questions that we think we know. And when I think about operative ultrasound, I put it into 3 buckets: to find out or evaluate what we know, to find out what we don't know, and then to guide us in doing certain things, gives us an advantage to doing certain things. So you may say, well, Hagopian, where'd you ever get this interest from? Well, I have to give all of this credit to my mentor, Hamid Bismuth, who I did my HPB surgery with, or actually hepatobiliary surgery with, training. And he really is one of the proponents of use of operative ultrasound in hepatic surgery. And he speaks about the 3 pillars of hepatic surgery. First and foremost is liver anatomy, and secondly is ultrasound. Thirdly is vascular control, but ultrasound is one of the pillars of excellence in hepatic surgery. And that's why AHPBA feels that it's very important to incorporate into your training. That will, which I'm sure all of you have started, and we'll give you some instruction next week. So in the liver, as probably most of you know, as I said before, how do we use ultrasound and how can it help us? Well, we can find out, we can evaluate those lesions that we know. We're taking somebody to the OR, colorectal metastasis. We know we have 3 lesions in the right liver, and we use ultrasound to evaluate not only those lesions, but then also to evaluate the rest of the liver. What is the extent of it? What is the presence of other lesions? And then we can use ultrasound to guide that procedure that we perform on the patient, whatever it is that we deem is feasible. So we can identify the extent of known disease, the presence of vascular involvement, and of course, in certain diseases such as pancreatic cancer, we may use it to stage disease and look for hepatic metastases. And then, of course, as I spoke about, identifying unknown or occult lesions within the liver. This is an example of a patient who was taken to the operating room, you know, one known lesion, as you can see here. Hopefully you can see my cursor, one known lesion identified here in the liver. I knew about that prior to surgery, but then as I carefully looked at the liver, I found not only that, but also multiple other lesions, you see as depicted by the arrows. We can also identify not only these occult tumor, but also with very, very, very good precision the proximity to vasculature, which is another important advantage of ultrasound, intraoperative ultrasound. And then we can also use it, as I said before, to guide what we do. We can use it to place needles for either biopsy, targeting, as some of you probably have already done in your fellowship. We can localize those lesions that we know of. We can determine, is it resectable? What is the extent of the operation that I need to do in order to remove all of the disease? And of course, we can also use ultrasound to real-time guide our resections. We use this in open surgery, but it becomes oh so more important, as you all know, in laparoscopic robotic procedures, minimally invasive procedures where our hands are taken away from the organ that we're operating on, right? And we're only using instrumentation, and ultrasound becomes even more imperative. And of course, at the end of the procedure, confirmation of completeness of the procedure. So we all know what we use ultrasound for in the liver, but what about in the pancreas and the biliary tree, right? But there's lots of applications that you will hear about next week in pancreas and biliary ultrasound. So specifically in the pancreas, we can determine the extent of vascular invasion, extent of the tumor, drainage of cysts, etc. This is a slide courtesy of Dr. Scott Helton, who I know is out there. Thank you very much, Dr. Helton, for this beautiful slide that actually was taken from a chapter that he wrote in our ultrasound book. But this depicts a tumor that is in the head of the pancreas, is causing obstruction on the pancreatic duct, and you see that there is invasion here of the SMV, but the SMA is clear. So we get extremely good pictures with the use of ultrasound. And we also can identify lesions in the pancreas that we may not have seen on CT scan. This is an example of a patient who presented with abdominal pain and a dilated pancreatic duct. CT did not demonstrate a lesion, neither did endoscopic ultrasound, believe it or not. However, at laparoscopic exploration, she was found to have this hypoechoic mass in her pancreas that was obstructing the pancreatic duct, which was a neuroendocrine tumor, and that she underwent resection. So what about in the biliary tree? Lots of applications there. And most of what we do, you know, the general surgeons can use it for gallstones, for gallbladder polyps, for choledocholithiasis, for oncologic diseases. We can use ultrasound to determine the extent of a tumor, and it is very useful for that, not only in the biliary tract, but also in the gallbladder. Examples of biliary ultrasound. So what about training and surgical ultrasound? This has always been the crux or the challenge, and we'll talk about it more next week, is really getting proper training in surgical ultrasound. Which is why we have built a course specifically for all of you in ultrasound. It begins with a course in the beginning of your academic year that hopefully you will participate in next week. And then you practice in your fellowship under the direction of your faculty and your program directors. You practice those skills, and at the end of the year, then we determine your competency with testing just before graduation. So how to get formal training in ultrasound? It really starts with that formal training and mentorship. And of course, that deliberate practice in the operating room every day that you do a procedure, pull out the ultrasound, and that's how you get to mastery of surgical ultrasound. And I know that was really fast to go through for all of you. But my goal was really to just give you a very brief introduction to what we're going to be talking about next week.
Sometimes, but anyway, I want to appreciate Dr. Rohan to ask me to tag team this talk with him about HPB essential imaging. He's going to talk about MRI, and he asked me to talk about CAT scanning. I thought it was a little bit of a weird topic, but I can roll with the punches anytime. I don't think he was talking about this, but I think he was actually talking about this with CT scanning. Anyway, I don't know if anybody's seen an uncovered CT scan before, but this is actually what it looks like. And if you look really closely at it, you kind of see this. So it's kind of crazy that people would actually get into this thing. Is this thing on? I can't tell. Is this okay? Anyway, well, moving on. So when it comes to CAT scanning, we're hepatobiliary people, and I'm going to run through some things you may or may not know about CAT scans, but talk a little bit about liver, specifically CLAT scan, pancreatic CTs, and the complicated patient. So when we as hepatobiliary surgeons order CT scans, we're not ordering most of the time usually abdominal CT scans, the things that get done in the emergency room. Typically those scans are done with a very late contrast phase. You can see the contrast in the collecting system here. And the things that we're usually primarily interested in usually need a little bit of an earlier phase of contrast to enhance or expose the things that we're looking for. Modern CT scans usually have 64 rows of detectors, and they acquire data at about 0.625 millimeters. And then as they're acquiring the data, those data can be reconstructed in any way that it's ordered, in 1 millimeter, 2.5, 3 millimeter, 5 millimeter. Nobody really does 10 millimeter cuts anymore. But again, as I mentioned on the abdominal CT scan, the IV contrast phase is usually out about 2 minutes, and that's usually called the renal phase. And again, most of the things that we look for are usually washed out by that time. When we're looking at a standard liver, we want to get a CT scan. Again, every institution may be a little bit different, but usually a 3-phase scan is typically what we'll order. That would include a non-contrast phase, an early arterial phase at around 20 seconds, and a portal venous phase at around 70 seconds. Again, variable, and I'll explain how that's variable. But these are just the different phases of the same patient: a non-contrasted phase, arterial phase, you can see the contrast in the aorta, and the portal venous phase a little bit darker. And then sometimes on the arterial phase, which is usually the hardest phase to read because there's so much noise in it, this is oftentimes where you can detect small lesions that may not be detectable on other phases of CT scanning. Now, as I mentioned, the timing isn't exactly set as it used to be in the past. Usually now what they do in the modern centers is contrast monitoring. So what they do is give a contrast bolus, and then you'll see this on the first images of contrast. They usually say a monitoring phase. And what they're doing is they're looking at the Hounsfield units within the aorta. And then what they do is the radiologist can go back and reconstruct the images. And actually, these things that show up on all our CAT scans, that's actually what it actually is. Here's the Hounsfield units of the contrast bolus. And basically, based on the levels of contrast, they can give you the ideal arterial or portal venous phase that you're actually looking for. From an anatomical point of view, run through this really quickly. You guys should know this by now, but here's a portal venous phase looking at the portal vein bifurcation. You can see the left portal vein here, and here's the right portal vein with the bifurcation of the anterior and posterior sectoral branches. Further anatomy, here's the left portal vein. You can see it sort of as it's turning up on the left and just after the bifurcation on the right. But these are helpful for anatomic definitions. So lateral to the left portal vein turn would be the segments 2 and 3. And then posterior to that would be the caudate sitting on the front of the vena cava. A huge anatomic landmark is the middle hepatic vein, as clearly seen here. And this defines the differentiation between the left and the right lobes of the liver. A little bit higher up, you see some beautiful veins here. You see the middle hepatic vein, as we just saw. You see the left hepatic vein and the right hepatic vein, and this divides the liver into sectors. So we have the left lateral sector, segments 2 and 3, the left medial sector, which is 4A and 4B, the right anterior sector, which is segments 8 and 5, and then the right posterior sector, which is segments 7 and 6. On a ClatScan protocol CT, it's similar to a regular liver CT. However, you usually add another phase in, as well as a CT celiac angiogram. So in the old days, the Dr. Jeyarajah and Iannitti days, it was a 15-minute delay. Then it sort of went down to a 10-minute delay because now the world is ADHD. It's down to a 3 to 5 minute delayed phase. Usually it's the angiographic phase in a ClatScan protocol CT is usually less than 20 seconds. Here's the arterial phase here. You see biliary dilatation, you see the arteries, portal venous phase, and here's the 10-minute delay here. And it's oftentimes on that delayed phase where the tumor actually uptakes contrast and you get a little bit of enhancement of the tumor. So you actually primarily see the tumor. More important for us is the vascularity. And so this is planning the CT angiogram. And usually we'll get a beautiful CT celiac angiogram with 3-dimensional reconstructions to help us determine level of vascular involvement and plans for resection. Other things that come up on CT scans, cysts here. On the left, you can see a simple hepatic cyst, thin-walled, no septations. On the right, this would be a typical biliary cystadenoma with internal septations and debris and things like that give you a little bit of a red flag. What we see a ton of here are liver abscesses, small liver abscess, on the left. These are often multiple small abscesses or more often caused by, say, cholangitis, where disaster liver abscesses, as you can see here, from either GI, skin, dental, or whatever. Other common tumors we see are hepatic adenomas, usually iso-intense relative to the liver. It's a typical focal nodular hyperplasia, a little bit of a delayed phase, but usually hypervascular with a central scar. And then on the hemangiomas, on the early arterial phase, the typical finding would be peripheral enhancement. And as you go later and later out in the phases, the contrast fills in. Again, quickly, HCC can look like a variety of uptakes. Metastatic colon treated with chemotherapy usually are hypo-intense. And then oftentimes for metastatic neuroendocrines, it's that arterial phase is where you're actually going to see the most lesions. It'd be remiss of me not to show a post-ablation scan. This is a hepatocellular carcinoma that underwent a beautiful laparoscopic microwave ablation with beautiful clear margins. So hopefully that will inspire everybody to continue to consider microwave ablation as definitive therapy. And real quick for pancreatic scanning, usually a pancreatic protocol CT, usually 3 phases as well, but just notice here, the arterial phase is about 20 seconds after a liver scan because they want the pancreas to uptake more contrast before they give you the arterial phase. From an anatomic point of view, beautiful view of the celiac axis, as well as the takeoff of the SMA. On the sagittal views, typically I often look at the sagittal views. I think they're underappreciated, particularly in pancreatic surgery. So I see a lot of personal value in reviewing the sagittal views of a CAT scan. Now remember that pancreatic cancer comes in a spectrum from radiographically resectable to locally advanced, and everybody has a little bit of definition between. But radiographically resectable typically means it's off the celiac or the SMA vessels, nice preserved fat plane there. A little bit less, more borderline would be where the tumor, and again, this is, definitions vary from institution to institution. I know we have some standards out there, but usually a tumor sort of kissing or involving the venous system, we would consider that resectable. And then for locally advanced, and this is locally advanced, where the tumor is involving the superior mesenteric vessels, and beautiful view on the sagittal view involving the superior mesenteric artery. And then this is actually truly locally advanced where the celiac and SMA are completely encased in tumor. And then this is sort of bad when you see a pancreatic adenocarcinoma with tumor extension into the lumen of the portal vein. And yes, that does happen with pancreatic adenocarcinoma. And then sometimes you can see gallstones, which are often radio-opaque. And then from pancreatitis, we do a ton of pancreatitis. Some of the complications that we see would be bleeds. You can see a nice arterial blush of a nice bleed from pancreatitis, walled-off pancreatic necrosis, and this is formalized more into a pancreatic pseudocyst. And finally, complicated patients, what do I mean? Contrast allergies, always a big deal. Need to take a thorough history of the patient. If they've had itchiness or hives, generally, they usually don't treat for that. If they have a history of anaphylaxis and particularly bronchial or laryngeal spasm, those patients should be premedicated, and generally you want anesthesia available. If you can consider switching to an MRI, there's usually low cross-reactivity between contrast, CT contrast and gadolinium or Eovest. Every place is going to have its different protocols for contrast allergies. Here are ours in the elective as well as the urgent or emergent CAT scan settings. And then finally, what do you do in patients with renal insufficiency? Again, places will have different thresholds. Traditionally, we've used creatinine, but more recently, the radiologists lean on the GFR. So a GFR of less than 30 would be a red flag. And in those particular situations, there's really nothing you can do. So you got to really weigh the risk-benefit ratio of getting a contrasted CT scan on those patients. Clearly, those patients need to be hydrated before, during, and after. And then if possible, consider a non-contrasted MRI, because you may be able, even with non-contrast MRI, you can still pick up things that might be useful to you. So with that, that is the end of the CAT scanner, and hand it over to my good friend, Dr. Jeyarajah.
Okay, well, thank you, David, and thank you so much. If you could unscreen share, perfect. Thank you so much. And I put this in the chat, but you guys need to understand that you are with Dr. Iannitti. He's literally, moved the needle on so many things to do with liver surgery, and not just his thing, but also to just mention that ablation and many techniques to use with ablation, including the use of color as you're ablating, which I've learned from Dr. Iannitti, really has just changed things for me and for many of us. So welcome. So this is supposed to be an imaging talk, and we thought that having surgeons do this might be helpful for you all, since we are trying to make it very focused on what's relevant for us as surgeons. I'm going to be talking about MRI, and this was partly because nobody else was thrilled about this topic. I personally love MR as a topic, and so I spend a lot of times with MRI. And what I did when I was at UT Southwestern is I used to go and sit with the MR radiologist on a Friday afternoon and read with them, because it was the only way that I could learn how to get over this. And this was in the days of hanging up films. So just a couple of things. I've got very little time, so I'm just going to focus on liver. I'm going to focus on how MRI works. I want to talk about contrast agents. I want you to come away with just very few basic understandings about the phases of scan. So just really briefly, remember that an MRI works by having a magnet of varying magnitude, and that's a Tesla. And then you have an external radio frequency field. And what happens is the magnet off, your electrons, your protons are not aligned, magnet on, you then hit it with a radio transmitter field. And as you turn the radio transmitter off, you get energy released. And by knowing what you're getting released, you can tell how much fluid, fat, etc. that substance contains. Now, there's some specific factors with MRI that I know you all know, but remember that the larger the bore, especially for very obese patients, can cause a lot of field effect. And so you see this kind of ringing effect around the edge of a very large magnet. Also, we always tend to think that a higher field strength means that it's a better scan, and that's not always true. This is true for neuro or musculoskeletal, but not necessarily for abdomen. So I'll show you some scans, but a 3T scan is not always better than a 1.5T scan. The magnet location also is an issue, and so sometimes we'll use a rectal coil, for example, for rectal protocol scans, or a breast coil for breast imaging. Breath hold is also critical, and these patients need to be able to hold their breath. We are getting better now with faster scanning and with respiratory gating, but pretty much compared to CT, where we can get, a huge slice scan within a few seconds, MR still takes longer. So with regard to contrast agents, so you want to look at vascular agents, and you're really going to be thinking about things that are gadolinium-based or a hepatocyte-based agent that will give you let me go back to my presentation, a hepatocyte agent that will give you a vascular phases too. The hepatocyte agent that I'm most familiar with, and I think many of you are, is Eovist, and we've actually written on this, and it gives you've got to set up this protocol, and let me tell you, your radiologists don't love this and your techs don't love this because of the delayed phase, which is at 20 minutes. So you get arterial and venous phases and then delayed, and you get a free cholangiogram with this. So please remember this. This is a great tool because at the 20-minute scan, you'll get a free cholangiogram. This is a little bit of historic interest because I don't think many of us are using it, but Faradex or Rezovist, which is a reticuloendothelial cell iron-containing compound, is actually quite helpful when it comes to using for FNHs, because you're supposed to have more RES cells in an FNH than background liver, so it drops out compared to background liver if you use this. So I love Eovist. My radiologists get get frustrated with me because I order Eovist on a lot of my imaging. And the pros are that if you do the phasing right, you get good vascular information. You can tell because it's taken up by hepatocytes if it is a hepatocyte-containing lesion or not. So a MET will drop out on the hepatocyte phase. And you can also see biliary anatomy. So you get a free cholangiogram for this too. The downside is it's delayed, meaning that your last phase, the hepatocyte phase, is at 20 minutes, and the patient has to be very patient, literally, and your techs will not love you because you tie up the machine. So this is a problem with Eovist. And you just need to remember that sometimes it's okay to use gadolinium. For example, hemangiomas are well seen on gadolinium, and so are FNHs with a central vascular scar as long as you get a good arterial phase. There is sort of the myth that Eovist doesn't give you as good vascular information, but really, if you set up your phases right, you will get good vascular information. The other thing is with HCC, because you're looking at a LIRADS, which is washout, you can use just GAD, but I find that the hepatocyte-containing agent also helps you with HCC, and the in and out phases to look for lipid can also help you. So a couple of things, just big things to remember is T1, fat tends to be bright, and on T2, water, stagnant water tends to be bright. So if you remember that, that is critical. And so if you can just start out by thinking of this, if you look at the CSF and it's dark, it's most likely a T1 weighted image. If you look at the CSF and it's bright, it's going to be a T2 weighted image. I know that sounds really very basic, but so many people get so mixed up on the phases that at least if you can start with T1 versus T2, that's going to be your critical thing. Now, remember, one of the big misconceptions is that you need to give contrast for an MRCP. You do not, correct? So this is a good study to do in somebody with renal failure or with renal dysfunction. And when you order this for a straight stone protocol, this is just a heavily T2 weighted image, okay? So they've just taken this, done it very heavy T2, and then got the appropriate cross-sectional imaging to reconstruct. Diffusion weighted imaging is good for finding abnormalities. So this is a good little screening tool to see if you've got something in the liver. So what my radiologists do, when I look at probably one of the best radiologists that I work with, that actually, for those of you from WashU on the call, trained at Mallinckrodt, what he does when he's looking at a metastatic colorectal patient or neuroendocrine is he starts out with the diffusion images. He just looks at it to scout it, to see where he's going to see a bright spot in the liver. Now, remember, diffusion weighted images doesn't mean you've got cancer there, but it is highly concerning for a malignant process in the liver or rapidly dividing cells. Lymph nodes will show up as positive or hot on diffusion weighted imaging. So just to show you this is a diffusion weighted scan showing us a metastatic colorectal tumor in the liver. And you can see that you've got a lymph node that's also lighting up too. That does not mean that the lymph node is metastatic. Lymph nodes will show up on diffusion weighted imaging. I wanted to show you this because this is the impression, right, that you would get a diffusion scan and a 3T magnet and it would be better, but this is the image from a 3T magnet as opposed to the previous one, which is a 1.5. So just because it's a higher magnet strength doesn't always mean that you're going to get a better imaging. The confounding factor here is that this is also a larger bore magnet. So that's an issue. So let's go through a case quickly. This is a 60-year-old man with colon cancer resected many years ago. I won't go into history too much, but he had a liver mass and was sent to me for resection. So let's go through what the CT shows us. And I just want to drag this through slowly so that you can see that we're dealing with a centrally located mass. And you can see that if I go to this cut, oh, sorry, I'm going to pause this and drag it. But if you go to this cut, you've got left portal vein, and you're wondering about relationship to right portal vein over here. So while I love CT, I worry about what this does with regard to relationship to other structures. So let's now, I just need to move my bar out of the way, sorry. Let's now look at the relationship of this with MRI. So I'm gonna, this is our, I'm sorry, I've just got my screen bar of everyone in place over here over the imaging, so I'm just moving that out of the way. But if you look at this, what we've got now on a T1 weighted MR is you can see the lesion in the liver. This is an arterial phase, so this is going to be a 20-second image, and you can see the blood supply to this liver. Now, if we move on and go to our T2 weighted images, remember CSF is bright over here. You see gallbladder is bright. You see this lesion, and you can begin to understand now from MR that you're getting the impression that those left bile ducts are just a little bit prominent. He had normal bilirubin, slightly elevated alk phos, and now you can see the relationship to the right bile duct over here, as well as the relationship to the portal vein, which on this black blood sequence, which is a flowing blood sequence, looks black. So you can see that obviously we're concerned about relationship to structures. Now we come to our T1, so CSF is dark, 60-second image, right? So now we're going to see the portal venous system, and you can see again, this thing drops out, but you can see the relationship to the portal vein, and of course, the bile duct is right in front of it over here. And now let's go to the 20-minute hepatocyte. So this is a ERVIS scan. And so your liver is going to turn white on ERVIS, okay, because you've got the hepatocyte containing agent. And your lesion is going to drop out, telling you that this is a non-hepatocyte containing compound. But look at this. You've got the left bile duct that is now excreting ERVIS. And you've also got your right bile duct here showing you the proximity of this thing to the right biliary tree, okay? And so, you know, now just to show you what the diffusion weighted imaging looks like, it's kind of what I showed you on the previous scan. You've got this large area of diffusion restriction, which is concerning, and then you've got this node over here. And so this is a good place to start because you can see that things just jump out. Okay, just one last thing before I finish up is pulsation artifacts. So remember that depending on your field of acquisition, you may be acquiring vertically and you may see a lesion that looks like a true lesion, but is actually artifact from the liver. So look over here. So this looks like it could be something in the liver, but it's actually directly above the aorta. And this is pulsation artifact. If you know that your lesion is sitting in segment 2-3 of the liver, you might want to talk to your MR techs about acquiring this way so your pulsation will be out here, okay? So this is just something to keep in mind. Now, I also wanted to show you this because if you look at this image, you can see that, let me pause this again. You can see that you get the cholangiogram phase on this delayed ERVIS. You can see the bile duct here, and then you can see this, patient with a infiltrating cholangio on this left side. So this is nice to use diffusion and also your ERVIS to try to get to this. So I just wanted to sort of outline MRI for you all and just give you a very, very brief overview. I wanted to tell you, just leave you with two other things. One is the issues related to nuclear medicine. Nuclear medicine still has its place. I'm a huge fan of DOTA scan, especially, and I think it's a really fantastic scan. Sometimes too sensitive, I can ask my Stanford folks about this, but we sometimes will find bony mets in patients that seem to have no other side of disease and we don't know what to do with it. The other use of of nuclear medicine is to look at hemangioma. You can look at a tagged red cell scan because it'll hold on to it delayed. And also sometimes a liver spleen scan is helpful in those patients. The last thing is, of course, IR and fluoroscopy. Don't forget that there are really some reasonable things to do with regard to fluoroscopy, and I would advocate that you get good at this because this is really a very nice tool, especially in foregut disease, and also cholangiography. So without further ado, Dr. Hagopian, I hope I stuck to time.
Full screen now.
It looks good, Paul. Thank you.
Okay. All right. Good enough. So, sorry for I'm showing a little bit of my age and my inability to easily manipulate these things. It's really a pleasure to be asked to participate in this, and I'm actually I have to give a real congratulations to you guys for pulling this off because this is quite a technical feat here to have this many people on from across the entire country. So I was asked to talk about kind of post-operative management of major hepatectomy. I did my first major liver section, now what? And as I sat down to think about, reflect on how I wanted to approach this, one of the things I was struck with is how much progression we've had in hepatobiliary surgery over the last 10 to 15 years. I joined the AHPBA back in 1997, and I think so much of what we may take for granted today as kind of knowledge about how to approach these hepatobiliary cases just didn't exist only a few years ago. When I did my training, which wasn't all that long ago, it was still routine for a for us to place a nasogastric tube in every single patient who had a laparotomy. The nasogastric tube stayed in until the patient passed gas. Then you did clamping trials, and then you had a couple of day progress of starting them on clears, fulls, softs, and they'd be 10 or 12 days in the hospital after a right hemicolectomy. And that was considered the dogma of the day. I mean, we just knew that was the right way to provide good care. So things have changed dramatically. There's a lot to learn, but part of what our problem has been kind of applying the knowledge that we've gained over the last couple of years. So Dave Urbach was one of our early fellows. He's up in Toronto at this point. He wrote a paper describing variation in surgical care. And his comment was that the immediate challenge to improving the quality of surgical care is not necessarily discovering new knowledge, but how do we integrate the things that we already know? And so that was kind of how I approached this talk. So I'm going to talk about major hepatectomy postoperative care, but I can't really talk about good postoperative care without some discussion of good preoperative and intraoperative care as well. We have a patient care pathway which is set up to kind of running these patients from beginning to end, and it involves a hepatic ERAS program. And so I'm going to kind of walk through some of the thoughts as to how we put ours together. So for enhanced recovery after surgery, ERAS, you all know the term at this point, but it really is about getting patients back as early as possible to a normal quality of life. And then, and maybe even more importantly, in some cases, getting them back to their next phase of cancer care. And the idea is that you're going to cover all the variables you can of perioperative care, and that this should be really data-driven. Ideally, we would have high-quality randomized clinical trials to answer these questions, but that, of course, doesn't exist everywhere. I do caution you to take other types of data with a bit of a grain of salt. There's a lot of bias out there that comes out in large non-randomized reviews of literature, and I think that's where a lot of the dogma that we have learned over the years comes from. And so dogma is a principle or set of principles laid down by an authority as incontrovertibly true. And I cannot begin to explain the number of times over the last 25 years of my career that I have had to lay down the dogma that I absolutely knew was correct, and it has now subsequently been proven inaccurate or dangerous in some cases. So be willing to change your process, be willing to adapt with time and with new data. Although ERAS has been talked about since the late 90s and the first publications in the early 2000s, it wasn't until 2016 that the ERAS Society published their first guidelines for liver surgery. And it was a Delphi process. 7 liver experts, I guess it was hard to find many liver experts, but one of them was American, most of them were European, and a couple from Asia. And they reviewed the data that was available at the time, and they were able to come up with information on 23 variables of care that they included. 16 of the 23 were derived from liver surgery data, but at that time, 7 of the 23 didn't even have liver surgery data, so they adapted colorectal and general surgical data. And it's really unclear whether the elements validated for colorectal and general surgical ERAS can extrapolate to general surgery. The pathology is obviously different. Liver function, if you have patients with cirrhosis, that completely changes the game. And so you do have to be cautious in applying those same principles. The quality of the data overall was not terribly strong. The quality and strength of evidence, there were 4 of the 23 recommendations where they thought that they had high quality data and they made a strong recommendation, and there were 9 that had moderate quality data and strong recommendations. The rest were a combination of weaker data and weaker recommendations. And I'm going to go through some of those in the next few slides. The one kind of summary thing that I would say is that ERAS has been very clearly shown to reduce complications, but it's really medical complications that it's reducing. The surgical complications are largely unchanged. And that's why I think that I felt strongly that I had to include some preoperative information as well as intraoperative management recommendations. And that's the only way you're going to get good postoperative outcomes. So just one slide on preoperative management. And I truly think this is probably the most important thing we do. So we have a preoperative checklist that when I walk out of a patient's room, the first thing I do is I go talk to our scheduler and assistants and sit down and walk through the checklist with them. Every patient gets presented at a good, true multidisciplinary tumor board. The days of surgeons making these decisions, big decisions on their own and just kind of running with it are gone, and they should be gone. It really needs to be a combination of your rad-onc and med-onc and GI and radiology. The rest of the checklist, making sure you got complete staging, make sure you got the appropriate timing of your labs and your imaging, looking at assessing your liver as far as future liver volume and the viral and alcoholic screening that should take place. Every single one of our patients goes for high-risk surgeries goes to a preoperative clinic. And our clinic, we're fortunate, is run by an anesthesiologist whose entire career is devoted to optimizing patients for high-risk surgery, and she's absolutely fantastic. And we also screen the patients for research eligibility for clinical trials. And then one of the things that we added about 2 or 3 years ago was just a formal weekly review. So we sit down at every Thursday and we look at the entire list for next week's cases to make sure, and this is when we take the opportunity to go back and make sure we got the liver volumetrics, we check out the echocardiogram, you kind of do all that basic, make sure all that basic background work is in place a week ahead of time, so you've got some time to respond if you're missing some information. We have a strong prehabilitation process. It's again managed through our pre-surgery clinic. So the patients have access. There's anemia protocols which talk about oral iron or IV iron. There's diabetes protocols. Very actively take on alcohol and smoking cessation. Very actively get them into physical therapy. Nutrition, I've highlighted in blue here some of the variables that actually have the strongest data behind them. There's great data that would suggest if you've got a patient who's had significant weight loss in the last few months or has an albumin below 3, that if you give them 7 days of PO nutrition preoperatively, that you can significantly improve their outcomes, psychosocial and neurocognitive evaluations. The other place on this page that has is in blue is patient education. There's again very strong data that if you take the time to educate your patients preoperatively, that their outcomes are going to be better. Knowledge reduces fear. These patients, whether they show it or not, are going to be scared to death. Most of these patients have no prior experience with this kind of surgery or this kind of a medical event. It's likely the biggest physical thing that's ever happened to these patients in their life, and they're now 70 years old. It affects every aspect of their life, their family, their finance, their future. So you really do need to spend this extra time with them preoperatively and make sure they understand what they're getting into. And I use this time to set expectations, and this is a huge payoff post-operatively. If the patients understand that what their experience is going to be in the operating room, that we expect them to get out of bed, that we will give them early access to food, and how long their hospital stay is going to be, it really sets them at ease. And so it's worth the investment. So in the operating room, I break it down into 2 areas: anesthesia and surgeon's responsibilities. And so anesthesia, and interestingly, you'll notice that the blue here, the things where there's the hardest data behind them, is actually there's more of it in the anesthesia realm than anywhere else. For our preoperative regimen, we use preemptive pain management with a COX-2 inhibitor, Tylenol, and gabapentin. Anti-nausea preoperatively. Our antibiotics are given an hour preoperatively. We get sub-Q heparin preoperatively. You have to be careful here with the timing if you're using epidurals. I'm not an epidural fan. I went through that phase, and I felt like too many of my patients were having problems with post-operative urine retention or with fluid. They were sucking up fluid and we couldn't really tell if they were bleeding. Their pressures weren't very good. A lot of these patients ended up in the ICU that really did not need to be there. And so we switched to intrathecal narcotics and have had really a fantastic response with that. We mix that with tap blocks. And we get some 12 to 24 hours worth of relatively good pain control before we start switching them on to other things. We have normothermia and normoglycemia protocols in place. There's hard data showing that these will reduce your post-operative wound complications. Fluid management, as most of you are probably doing the same thing with low CVP pressors rather than fluids to support them during the case. Really, and then blood management. Transfusions should be a fairly rare event, even in major hepatectomies. It should be in the 10 to 15% range, and I think you can get there. And this is all about communication, and primarily with your anesthesiologist. One of the biggest signs of a failure in my operating room is if I look up and I see this in the middle of a case and I wasn't expecting it. Anesthesia has hung blood. They haven't communicated with me. They're not explaining what it is that they're concerned about. To me, that's a problem, and it's my problem too, because I need to make sure I'm in touch with the anesthesia throughout the case. The surgeon's responsibility in the operating room for good long-term outcomes. It sounds a little cheeky, but it's just have a plan. And we all know the patient's going there for a right hepatectomy for their colon mets. But the reality is there's a tremendous number of things that can go differently than you expect. You go into the operating room, you take a peek in, and the first thing you see is the patient's got some sort of fibronodular disorder of their liver that just didn't show up for whatever reason on the CT scan, or they've got they've got worse steatohepatitis than you expected. They have more tumors or tumors of a different type, or they've got other extrahepatic metastatic disease. You want to have thought through all of those things before you walk in the door, and more than that, you want to have discussed it with not only your team in the operating room, but with the patient, so that you know in some different kind of more common scenarios what your patient would want. Interesting from a technical perspective, the one thing that keeps coming up, is having good data to support it is really just the incision type, and you need to get away from the Mercedes incision if you're still using this. There's a fair bit of data out there that shows that there's more pain associated with this. There's a higher hernia rate, and I will argue that the access to the abdominal cavity is not as good as what you can do with an L-shape or hockey stick incision. If you have an obese patient and you're trying to push this down to the bottom of your field, that's a much harder thing than actually making the incision drop lower and flipping this up over the costal margin. And you can get really tremendous access with this incision. The lateral aspect of this incision is really all about mobilizing the right lobe of the liver so you can get up to the vena cava, or you can deal with the diaphragm. We actually have replaced this, even in our big open cases, we've replaced this lateral aspect with a couple of laparoscopic ports. You can do all your mobilization laparoscopically, and even in the case that I feel I have to do open, we'll just do it through an upper midline. The surgeon needs to have room awareness. You need to, again, know your anesthesiologist and be talking to them. You have to know what staff and resources you have available to you should you get into trouble. Blood management options, as we've talked about. One of my fellows coined this phrase for me, and they said, basically what I do when I walk into the operating room is I start doing catastrophic visualization. And I think it's a great term, and I think we should all do it. And so as we're walking through cases, and I've got my fellow, and they're putting the stapling device across a difficult to reach middle hepatic artery, I'll stop and I'll say, okay, what are you going to do when something goes wrong? Let's say that staple line doesn't fire. Let's say the handle locks and you can't release the stapler. The clamp that you're putting on some big vessel falls off. What are your first steps going to be? And I can tell you every single one of those things has happened to us in the operating room, and our ability to respond to them appropriately and quickly and manage the catastrophe is markedly improved if we've all spent a minute thinking about it before we do it. It doesn't take that long. It's a great exercise whether something bad happens or not. And then the last thing in the operating room is technical. My fellows will tell you that rip and tear surgery is not allowed. We are very meticulous in our tissue handling. Blood loss is something that I consider that a bit of a failure. We all have it. I've had big blood loss cases that I know shouldn't have been, and it's usually something I've done wrong in the way that I've approached it. There are the occasional patients that there's no other good way to it, but that should be a rare event. And then efficiency, knowing the plan you've got and getting in and out of the operating room as quickly as you reasonably can. So now I'll step into that post-operative era, and that's so in the PACU, there's not a lot we do differently. If this has been a really tough case, a lot of blood loss, or maybe a Pringle maneuver, I've been clamping, doing a vascular reconstruction or something, then we'll spend some more time with these labs in the PACU. I want to understand their hemoglobin coagulopathy and whether they're managing their glucose appropriately, and if they left them with an acid-base deficit. All of those should be managed early on. And then the real question here is actually all about disposition. And in our institution, 95% of all of our hepatectomies go to a regular floor, and that includes all of our majors, including the rights and lefts and trisegs. But the reason I can get away with that is because our unit experience is outstanding. We have a great set of nurses up there. They see a lot of this. They expect it. They've got a good patient to RN ratio. And that may not exist every place. And so a lot of institutions have step-down units, and sometimes it's just appropriate to use the ICU. But think about this. It shouldn't just be a knee-jerk reaction. If you're putting in epidurals, that can affect this. And as I say, I don't use many. When I was using epidurals, it was much more common for me to send patients to the ICU. So for the post-operative, the ERAS variables, pain management for us, we've talked about some of this already because we've set it in place by our preoperative management. And that's so they get the preemptive pain management. We use regional anesthesia, which I really like. And then it's about polypharmacy. So we're mixing and matching the different drugs that we have available to us. And I really do try to minimize the narcotics. We don't torture our patients. I certainly use them. But the patients have been educated ahead of time about the problems that you run into with narcotics. And so, along with our ERAS protocols, we have a push button, often these are pre-populated pain management order sheets. Drains and tubes, there's good solid data showing you should not be leaving routine nasogastric tubes for hepatectomies, probably for most of our cases these days. We do not leave routine operative drains, and there's data to support that, although the data is a little bit less strong here. And I would argue this is more of a clinical scenario question. If I've done a complex biliary reconstruction or I've done a difficult dissection around the hilum, and I really am concerned that there could be some post-operative bile leak, then I'm more likely to leave a drain. I do a lot of white gauze testing at the end of the case, and we'll do some cystic duct stump cholangiograms where we'll inject air into the duct and put the liver underwater and see if there's any bubbling if I'm really worried about it. I'm sure most of you at this point are removing your Foleys and your IV lines early on in the management. Fluid management, again, we've set this up preoperatively. Patients have a reduced CVP, so they tend to come out of the operating room pretty dry, and you need to be honest with yourself about how much blood loss you've actually had. Most of our patients get a standard, just kind of a maintenance IV fluid with a balanced solution. And then I tend to bolus them as needed. And I do tend to alternate between crystalloid and colloid. There's some data that suggests crystalloid is probably better, but I just anecdotally have felt that patients seem to respond better and have, I think, have some fewer edema and pulmonary edema problems if you mix some colloid in. And then we make our boluses goal directed. So we're looking at vital signs and urine output as their primary goals that we're working towards improving. There's some interesting data. I actually just reviewed this paper again recently, and I haven't added this to our ERAS yet. And maybe one of you guys can comment on whether or not you're using BNP, but there's some data suggesting if you put the patients, you get scheduled BNPs, and then you use your that to guide your fluid bolusing, you can actually get to a better place early on with the patient. So nutrition and GI function, there is data here. Again, no NG tube, early access to liquids and solids. I get pretty much immediate access to liquids, and I kind of modify their solid access. I give them some light access on day 1, and then really general access on day 2. But I spend a lot of time educating the patient on this, and what I tell them is that the best measure of whether or not a patient's truly ready to start a PO diet is their own gut. And if you have a patient who's bloated and uncomfortable and not wanting anything, you do not want a nurse in there telling them that they have to eat a plate of eggs before they can go home. I let the patients moderate that to some large extent. Actually, one of the places where there was really good interest, good data, if you want to reduce your delayed gastric emptying, specifically in left hepatectomies, flip a piece of omentum up between the raw surface of the liver and the stomach. And there's a couple of randomized trials actually showing that reduces the incidence of delayed gastric emptying. Pretty simple thing to do. I just did it the other day. Physical therapy, you got every patient gets a PT consult, every patient gets out of bed, give them a log, have this in front of the patient and in front of the nurse so we can keep close track on how often they're actually getting them out of bed. Again, patient education, setting expectations is really where the money is here. If they know they're supposed to do it before they even have the surgery, it's easier to convince them of it post-operatively. DVT prophylaxis, again, preoperative dose. We start our low molecular weight heparin pretty much day one unless there's a significant coagulopathy. Although that being said, the coagulopathy from liver dysfunction is not the same as anticoagulating a patient. This does not protect a coagulopathy from having beat up the liver does not prevent your patient from getting DVTs and PEs. So you still have to work on the SCDs, early ambulation, and get them on a heparin or low molecular weight heparin as soon as you can. Essentially, all of our patients are high-risk patients. They're big cancers, big surgeries, and they're in the hospital in bed for several days. So all of them go home on 4 weeks of low molecular weight heparin. Again, solid data there. We do restart full anticoagulation pretty early. Most of the patients for liver surgery, it's the first 24 to 48 hours. And if they're not showing evidence of bleeding at that point, then I'm feeling pretty comfortable with most of the patients about restarting anticoagulation if I feel like it's important for them otherwise. Understand your disposition, planning early, know what their resources are at home. And again, it's all about education. Start talking to the patient early on. I think for time-wise, I know we're running behind, so I'm just going to say that every surgeon has complications. Obviously you want to minimize their occurrence by being careful and setting things up preoperatively, good patient selection. But in the hospital, it's really early recognition. And I probably overorder my labs and imaging, but I think that there's so much on the line for these patients. When they have complications, they tend to have big, bad complications. And so if I can get a CBC or some coags a day on the first day of their complication rather than on the third day of their complication, I think that improves our ability to rescue them. And so I do tend to be a little bit heavy-handed with labs and imaging. For those of you who know Chet Hamill, that used to make him crazy. Then last thing I'll say here is just if you're new and going out into practice, whether you're at a place that has an existing liver program or you're in the process of developing your own, you have to know the capabilities and limitations, your own capabilities and limitations, and then the resources that are available to you. Know your own data. This was the Lee Swanstrom thing. This is how he became who he ultimately became in the world of MIS surgery. Was he recognized in the late 80s that if you asked a surgeon what their wound infection rate was, they would tell you it was 3%, because that was what they read in the New England Journal articles a couple of days ago about whatever that type of case was. They had no idea what their own data showed. And so NISQIP 100% HPV capture has been absolutely invaluable in our ability to build a really high quality program and to counsel the surgeons that are participating in it. I can give them one-to-one data on what their transfusion rates are and what their complication rates are. And it really helped us as a group actually kind of understand our outcomes. And then finally, if you're building your own system, you absolutely want to have your patient care pathways and your ERAS protocols. Start writing them down, get your order sets in place, educate your staff, educate your patients early on. And I think you'll be off in a good setting. So I'll leave it with that. I hope it didn't run over too long.
Paul, thank you so much. That was very, very informative. Go ahead and unshare. For the purpose of time, we'll move on, and we'll still plan to end on time. We have a little bit of leeway with the happy hour right after this. But we have a great speaker coming next, and that's Dr. Nick Zyromski from Indiana University, Program Director, and obviously also the co-chair for the Program Directors Committee, talking about post-operative management in pancreas. Nick, do you have your slides as well?
Yes, I'm going to share my screen here.
Fantastic.
See if this works.
Perfect. We see it.
Yeah, great. Well, thank you so much. It's a privilege to speak on a program with all of these fabulous educators. The task I was assigned was to talk to you about immediate postoperative pancreatectomy problems. And the title of the talk, this was assigned to me, the drain amylase is 1,000 on postoperative day 1, now what? So I'll tackle this, and I will warn you that I'm going to make this a little bit interactive. So any fellows who might be dozing off here at the end of a long Zoom day, I'm going to call on some specific fellows. And if you don't answer, you get your happy hour drink chit taken away from you. My disclosures here, I have no financial disclosures. I do want to tell you that this talk is not a comprehensive literature review. It's addressing a very important clinical question from practical and experiential based perspective. This is our group at Indiana. There are 6 of us now. Actually, Dr. Trang Nguyen is a surgical oncologist who joined us in the fall. I need to get a picture with her in with the group. We have a very strong HPB program. We're essentially the only HPB program in the state of Indiana, catchment area of 6.5 million people. And we have a fabulous ERCP group, one of the best in the world, doing 3,000 ERCPs a year, nearly 30,000 upper EUSs. And so anytime anybody's close by, you're welcome to visit. Would love to have you in Indiana just for a drop-in. I'm going to tell you my take-home message here in the beginning, and I'm going to tell it to you again in the middle, and I'm going to tell it to you again in the end. Number one, we're talking about pancreatic fistulas. If the drain amylase is high, that's what the complication we're worried about. One of the main things you need to understand is whether or not the fistula is controlled, and I'm going to speak to that point a little bit more in a moment. I want people to understand that a pancreatic head resection is not the same as a pancreatic tail resection, a left-sided pancreatectomy, in the setting of a pancreatic fistula. And then we're going to take a sidebar to talk a minute about enucleation. And then the fundamental point is, regardless of what the labs show you, regardless of what the numbers show you, it's critically important to treat the patient who's in front of you. Oftentimes you'll have a patient with a high amylase in the drain, but the patient will be fine. And maybe you don't need to rush in and do anything particular about that. On the other hand, there are some patients whose drain is not positioned appropriately, and the drain and the amylase will be low, and the patient is not well. And in that circumstance, with a patient with an undrained, uncontrolled pancreatic fistula, some action needs to be taken. Why is this question important? Well, postoperative pancreatic fistula is very common, and it's a potentially lethal complication of pancreatectomy. This is the Achilles heel of pancreatic surgery. The incidence is different between head resection and left-sided resections. This somewhat ominous looking smiley face is to remind me to ask the questions of the audience here. But the point is that if you diagnose a fistula early, undrained fistula, and make an intervention, that's how we have the opportunity to rescue these patients. So let me ask Dr. Antonio Masi from McGill. Are you on the line?
Yes, I'm here.
Alejandro, sorry. What is the incidence of pancreatic fistula after a Whipple?
Well, it should be ranging between 15–20% pretty much.
That's an excellent answer. Yeah. And then how does that change if somebody has pancreas cancer versus somebody having pancreatectomy for a cyst or neuroendocrine tumor?
Well, it's going to be higher for when you have a soft pancreas, because in the pancreatic cancer, normally we have a desmoplastic reaction. So the pancreas is more hard, And especially if you have a pancreatic dilation of the pancreatic duct dilation, that's a given signs that the anastomosis could be more, less prone to develop a fistula. On the contrary side, if you do IPMN or mucinous lesion or whatever, the pancreas is more soft.
So Ellen, would you give him an extra drink ticket? Good answer. This is the pancreas fistula, and the definition of pancreas fistula before about 2005 was pretty nebulous. And so it would be hard for me to compare my outcomes with Dr. Hansen's outcomes in Portland or Dr. Alsadi's outcomes in Seattle or now San Francisco, Dr. Hagopian's outcomes in New York City. Claudio Bassi herded the cats of the International Study Group for Pancreatic Surgery together and came up with a consistent definition that was published in the journal Surgery 2005, volume 138, pages 1 to 13, stratifying pancreatic fistula as amylase greater than or 3 times the upper limit of your lab's normal on or after postoperative day 3. That's in a surgical drain, coming out of a wound, etc. This definition has subsequently been revised, and what was formerly known as the grade A fistula is now called a biochemical leak, and apparently not a fistula at all. But the B and C fistulas are so-called clinically relevant because they demand attention and or operation and cause severe morbidity or death. And my point is that this is a dynamic process. So you can't tell on day 1 with the amylase of 1,000, is this going to be a biochemical leak or is this going to be a B or C fistula? Dr. Bassi, for anybody who doesn't know, is a spectacular musician and a wonderful songwriter, and I'll encourage anybody to check out his songs, which are widely available. Claudio is a super guy. So here we are, post-operative day 1. Amylase is 1,000 in the drain. I'm looking at the other 47 participants. Is Blair Stevenson on the line?
I am here.
Blair, we got some options here.
Yeah, I'm not a fellow, but I'm on the business side for Dr. Iannitti. So.
Oh my gosh. Well, you better choose a bunch of these things that cost a lot of money. Why don't we move to Courtney Barrows? Is Courtney on the line?
Yes, I am.
Courtney, here's some options for you. Blair, thanks for being a good sport.
Sure.
Oh.
Day 1, amylase is 1,000. You want to get a CAT scan? You want to start TPN or sandostatin? Advance the diet, take them back to the OR, take the drain out. What do you think?
So I wouldn't do any of those first 3 options. I think that if they're otherwise doing well, you could start them on at least some liquids that day. Post-op day 1 amylase of 1,000. I mean, I wouldn't remove the drain, so I would just leave it in, see what it is on day 3. If it had been low on day 1, you could consider early drain removal at that point. But if they're otherwise clinically doing well, none of the other than advancing their diet options really are.
Great. Educated answer and good work. You get a drink ticket too. Here, so this is homework for every fellow. Ask yourself this question: does routine or directed administration of somatostatin analog affect the development of or clinical impact of pancreatic fistula? And here's the hint: multiple retrospective and several prospective trials are published. There's look up Peter Allen's work from Memorial, look up Steve Strasberg and the WashU group recently. That's a hot topic in this field. Here's a sidebar about drain amylase. What does this number mean? What is your magic number? What is my magic number? Is 1,000 on day 1 good or bad? Is 5,000 on day 1 good or bad? Should we check it on day 2, day 3, day 5? These are some data from our group. These are 415 patients who had pancreatectomy, had Whipples at IU but in the last few years. And we looked at drain amylase on the first 24 hours, second 24 hours, and third 24 hours, and it bounces around a little bit. So these are high error bars, but you get the idea that something that's 1,000 on day 1 is probably not going to be 1,000 on day 3. So here's the weird little smiley face. Is Jennifer, you on the line?
Yes, here I am.
Jennifer, what's your magic number for drain amylase?
I'll quote Dr. Hamill actually, since he's here with us. But I think like as long as the amount is decreasing, so even if it is 5,000 on day one, if it drops, substantially by day 3 when we check it again, I would leave the drain alone and then recheck it in clinic in a couple of weeks.
All right, I think that's reasonable. I think there's some good data out there from the Italian group, from Dr. Bossi's Verona group, showing that if the drain amylase is less than 5,000 on day 1, that's a good sign. The question about when to remove a drain is in the surgeon's hands, but I would encourage everybody to get drain amylases, especially if you're going out into practice. Why not get them every day and get yourself some data so you can actually see what's happening with these things? And then if you want to go back and study them, you can do that. An important point is that the cadence of the change is important, just like Jennifer told us. So on day 3, this guy's drain amylase may be 5,000, and you do something differently than if on day 3 it was 500 or 100. Here's another homework assignment. Look up some of the papers from the Verona group, from Dr. Chuck Vollmer, former president of AHPBA, from Dr. Henry Pitt, former president of AHPBA, and see what you think about those numbers. Let's see, I can't actually see my own. Oh yeah, here's risk factors for pancreatic fistula. There are patient risk factors and pancreas risk factors. Malnutrition, it's an interesting topic to think about. What does neoadjuvant chemotherapy do to wound healing or fistula development? What is the pathology of the tumor? As we alluded to previously, is this a cyst or neuroendocrine neoplasm, or is it a pancreatic cancer with obstructive pancreatitis and a firm gland? The clear risk factors for fistula from the pancreas: small duct, soft gland, and acute pancreatitis. And I would like to bring this topic up. This is not well known, maybe yet, but this is a hot topic. What about postoperative acute pancreatitis? What if you finish your pancreatic jejunostomy and you see edema in the soft pancreas here? This was a woman with a distal bile duct stricture who on postoperative day 1 had a serum amylase of about 500. Postoperative pancreatitis, or POAP, is a very interesting topic. There are 3 papers that are in press in surgery. This is to show you guys how hip I am. This is the surgery's Twitter handle right here. Check it out. They're coming up. And check out Sachs and Connor's very nice paper published in HPB a few years ago about postoperative pancreatitis. It's an interesting thing to consider, and maybe we could talk about that further if we have a moment to discuss after surgery. So with apologies to the bar, to drain or not to drain is an entire question in itself. And it would be nice if we were in a room to do a straw poll. How many of the attending HPB surgeons drain Whipples or drain distal pancreatectomies? Most of us at IU drain both Whipples and distals. One of my partners doesn't drain distals, or says he doesn't drain distals, and then occasionally he does. So who knows? I think, again, to make the point, there's a difference between pancreas head resections, pancreas tail resections. The one point I would like you to take home, if you do a central pancreatectomy or middle segment pancreatectomy or enucleation, I think it's an excellent idea to drain that pancreas, and I'll speak to that in one moment. One more homework assignment: look up Bill Fisher's prospective randomized multi-center trials. These trials were conceived at the AHPBA, a number of different groups, including our IU group. It was headed out of Baylor, but a lot of the people on this call contributed patients. The question was, should we leave a drain after a Whipple or a distal pancreatectomy? The spoiler is that the Whipple paper was stopped early because of mortality in the no drain group. The distal paper was a little bit equivocal. Both of these papers are published in the Annals of Surgery. So you can use the distal paper to do whatever you want clinically. This is a central pancreatectomy. Here's the pancreatic head. Here's the SMV and the portal vein. Here's the pancreatic tail. This is actually not my case, but you can see soft pancreas. This was a neuroendocrine neoplasm. And the central pancreatectomy or enucleation, the fistula rate is about 1/3. We understand this problem is going to happen more commonly, and this is the trade-off for parenchymal preservation. But when you drain these patients, please be vigilant to make sure that you have a controlled pancreatic fistula. Again, halftime here, a little bit more than halftime, but just to reiterate, the main issue is your pancreatic fistula controlled? And treat the patient, not the number. If a patient has a high amylase in the drain, a high volume in the drain, the classic dirty dishwater drainage, maybe you do a sinogram through the drain like this after a Whipple and you see the upstream pancreatic tail lighting up. If the patient looks good, the heart rate is normal, they're tolerating a liquid diet or full liquid diet or soft diet or wherever you are, then there's nothing to do but sit tight and potentially crack that drain. Different people crack the drains at different points in time. I typically wait for at least several weeks before I crack a drain to make sure everything is solidly socked in. You know, Dr. Hansen's point about complications are a huge deal for these patients. And we're often operating on very frail people. I don't see any reason to rush. What do you do for the postoperative fistula management? If the drain is not controlled, you got to do, if the fistula is not controlled, you have to do something to get control of that fistula. You maybe do a CAT scan to find whether or not there's an intra-abdominal collection. If it's amenable to percutaneous drainage, that's great. If it's amenable to transgastric drainage, that's great. But I would have a very low threshold to even take the patient back to the OR, which is not a crime in my mind, to get control of the pancreatic fistula, because uncontrolled pancreatic fistulas cause bad problems. Controlled external pancreatic fistulas, again, you got plenty of time and you don't have to rush into anything. And again, a fistula from a Whipple where the pancreatic juice is activated by the enterokinase, that's a very different story than fistula from the tail where the pancreatic juice might be a little more innocuous. We've all seen bad fistulas from the pancreatic tail too, so don't let that lull you to sleep. This flaming pancreas was drawn by my friend Steve Grapel, who's a medical illustrator, and I think everybody should have one of these. So if you want it, just email me after the talk and I can send it to you. I tried to get my wife to make me mud flaps for my truck out of this, but she put her foot down with that. What are the problems that are caused by pancreatic fistula? Sepsis, hemorrhage, delayed gastric emptying. In the long term, you wind up with a PJ stricture. But in the short term, these are potentially fatal problems. And so we pay very close attention to pancreatic fistulas and are very aggressive about trying to treat them. This is a pseudoaneurysm of the superior mesenteric artery right here after a pancreaticoduodenectomy. Here's undrained pancreatic fistula. So this fluid, the activated pancreatic juices are bathing these silk sutures that you put on the uncinate on the retroperitoneal soft tissue margin. This is a radiologic view of this. Thankfully, this patient was rescued. This slide, these are some data that we published now a long time ago looking at postoperative pseudoaneurysms of the visceral arterial tree after pancreatectomy and after in the setting of pancreatitis. The point is that they can occur just about anywhere along this visceral arterial tree. So it's very common to see these after Whipple from the GDA, from the splenic artery, particularly after a distal pancreaticoduodenal arteries, SMA, dorsal pancreatic arteries, but also up in the hepatic arteries, right gastric, and a number of patients have more than one pseudoaneurysm, so be very wary about this. Undrained pancreatic fistula can lead to delayed gastric emptying. This is, these are some delayed gastric emptying data from our hospital from a number of years ago. And in the long term, if somebody has a pancreatic fistula, I would follow that patient for a while, especially if this is a soft gland and a small duct. These are patients, when they heal, they scar, and they can have recurrent problems with left-sided pancreatitis from pancreaticojejunostomy stricture. So again, last slide here. What can we do to mitigate the risk of pancreatic fistulas? Do you put extra drains in? Do you use an internal pancreatic stent? Do you use internal external pancreatic stent, a la John Howard? What about octreotide or sandostatin, somatostatin analogs? Can you do other technical things? Different type of anastomosis, PG, PJ, dunking anastomosis, a la Charlie Yo? Do you delay your diet? Any other points? I'll direct you again to Dr. Vollmer's work. Dr. Vollmer has spent essentially his entire academic career studying very thoroughly this issue. And this is a good starting point for people who are interested in thinking about fistula risk mitigation. This is a short segment of a 5 French pediatric feeding tube. This is my strategy. If somebody has a high-risk gland, there is some data suggesting that this may not be a great thing to do. And this is one of the problems these feeding tubes cause. This is a guy who had pancreatitis and the tube got stuck, didn't pass. Almost all of them pass, but this guy wound up with recurrent pancreatitis from the stuck feeding tube and actually developed another stone in the body of the pancreas related to the tube. Our expert endoscopists were able to get back there with Whipple anatomy, which is an accomplishment in and of itself, but they were not able to remove this feeding tube. And so we actually had to go back to the OR to pull this thing out and revise that anastomosis. So again, just summarizing the critical points for take-home message. When somebody has a pancreatic fistula, the main question is it controlled? Head resection and tail resection yield different types of fistulas. And a critically important point, which tends to get overlooked, believe it or not, even in this day and age, is treat the patient, not necessarily your numbers or your x-rays. And I'd like to say thanks for this chance to talk. If we have a moment to take questions, I'm happy to do so. And if not, you're welcome to email me. I think that the organizers will send out all of our emails. So thanks for your attention.